Hello everyone. Welcome to the symposium Optimized Models of Care for TB Prevention Among Migrants, which is organized by KNCVTuberculosisFoundation on the occasion of the completion of the Endpoint TB program. We are sitting here in the studio in Amsterdam, but all of you are online, and some of our speakers are online as well. The symposium will be hosted by the two of us here at the table. On my left, at safe distance, is I don't know if you can see her. At safe distance, on my left is Susan van den Hof, who is with the National Institute of Public Health in the Netherlands, and I'm Frank Koblenz. I'm with the Amsterdam University Medical Centers and the Amsterdam Institute for Global Health and Development. We have an exciting program today of international speakers, again, some of them here in the studio and some of them online. Before we start, a few housekeeping arrangements. In the webinar, there are basically two options for you to respond. One is to use the Q&A. Those are meant for questions on content. Unfortunately, because of time, we won't be able to allow questions at the end of the presentations, but we will have questions at the end in the panel. So you can put your question there. If you have issues about technicalities, please use the chat function, because that is then someone will pick it up and try and answer your question. Make sure that you can hear or see what you didn't hear or didn't see. Another housekeeping arrangement for the speakers is that unfortunately, we have to keep you pretty tight to your time schedule. All speakers have 15 minutes. Should you run over, then we will let you know, and then hopefully you will be able to conclude your presentation quickly. As I already said, we will have a panel discussion afterwards when questions from the floor, from the audience, can be answered. So it's now then my great pleasure to introduce the first speaker for this afternoon. You can see here on the program that her title is DRS, which doesn't mean that she has multiple doctorates, but it means that in Dutch that she is about to get her doctorate. So her doctorate, actually she will defend her thesis tomorrow. Much of the work that she will be talking about is about her PhD thesis work. Ineke Spruit from KNCVTuberculosisFoundation, and her presentation is entitled Optimized Tuberculosis Infection Screening and Treatment Program Among Migrants in the Netherlands. Ineke, the floor is yours.
Thank you, Frank. Thank you very much for this nice introduction. Welcome, audience online. I have to. Yes, there we go. My name is Ineke Spruit, and I'm a TB consultant and epidemiologist with KNCVTuberculosisFoundation. And the past 5 years, I've worked on the TB Endpoint project. This project studied the implementation of optimized TBI screening and TPT among high TB risk migrants in the Netherlands. And during this project, we employed mixed method studies to assess the facilitators and barriers for this optimized program. And we employed mathematical models to assess the cost effectiveness and the impact of the TBI screening and TPT program. In the Netherlands, between 600 and 800 persons are diagnosed with TB disease annually. Of these persons, 72% in 2020 were foreign born, were born in another country, were not born in the Netherlands. Most of them were from Eritrea, Morocco, India, Indonesia, and Somalia. In the Netherlands, all immigrants coming from countries with a TB incidence more than 100 per 100,000 are screened mandatory at entry with a chest X-ray. For asylum seekers, these are all asylum seekers coming from countries with a TB incidence more than 50 per 100,000. In addition, immigrants and asylum seekers coming from countries with a TB incidence more than 200 per 100,000 are also offered voluntary follow-up screening, which is done by chest X-ray biannually for a period of 2 years. In the TB Endpoint project, we replaced the chest X-ray entry screening among immigrants with a TBI screening. Additionally, in a second study, we replaced voluntary follow-up screening by chest X-ray among asylum seekers coming from countries with a TB incidence more than 200 per 100,000. Additionally, because Eritreans have a very high TB incidence in the Netherlands, we also studied a community screening among settled Eritrean migrants in the Netherlands. The TBI screening consisted of TB symptom screening through a health questionnaire and a tuberculin skin test and/or IGRA screening. If one of the two was positive, the client was redirected to the TB physician for consultation and for a chest X-ray to exclude the presence of TB disease. As I mentioned, we executed 3 pilot studies, one among immigrants, one among asylum seekers, and one among settled Eritrean migrants. And we employed a mixed method study design in which we collected and analyzed quantitative data and qualitative data, for which we did semi-structured interviews with asylum seekers, TB care staff, and stakeholders. In the 3 pilot studies, we screened a little over 1,500 persons for TBI, of whom 20% had a TBI diagnosis. Of those with the LTBI diagnosis, 75% initiated TPT, tuberculosis preventive treatment, and 84% completed tuberculosis preventive treatment. Facilitators for the TBI screening uptake was to limit travel for the client to the public health service, and also limit the visits to a health center by screening directly with IGRA rather than TST and IGRA. A barrier for uptake of the LTBI screening was mobility of migrants. For example, it was a facilitator to bring the TBI screening to the asylum seeker center. However, at the asylum seeker center, when we were there, a considerable proportion of the asylum seekers had already moved out of the asylum seeker center before they were able to uptake the LTBI screening. For IGRA positivity and LTBI diagnosis, the reason for migration was associated with increased risk for IGRA positivity and LTBI diagnosis. You can see in the picture that immigrants have lower IGRA positivity and LTBI diagnosis than asylum seekers. Additionally, and very interesting, was that among the Eritrean asylum seekers living in asylum seeker centers in the second study, we observed a 22% LTBI diagnosis. Whereas among the settled Eritrean migrants in the community, we observed that only 12% had an LTBI diagnosis. This difference is possibly explained by the fact that a considerable proportion of the settled Eritrean migrants came to the Netherlands through family reunification and traveled by plane, whereas those living in asylum seeker centers traveled by ground. We have hypothesized, and this is also supported by other literature, that the Eritreans who traveled by ground have had increased exposure to TB infection during their travel to the Netherlands, for example, in Libya or in Sudan or in any other transition places that they have been. Other factors that were associated with increased risk of IGRA positivity and LTBI diagnosis were older age group, male sex, and lower levels of education. For the uptake and completion of tuberculosis preventive treatments, we identified that cultural and linguistically tailored verbal education were facilitators and very important facilitators for the uptake and completion of the preventive treatment. This was observed especially as we learned from the immigrants, from the pilot study among the immigrants, we learned that there was a need for improved verbal and written culturally sensitive education, which we applied and implemented in the pilot studies among asylum seekers and settled Eritreans. This is an important factor that contributed to the higher acceptance and completion of the tuberculosis preventive treatment among the asylum seekers and settled Eritreans. Furthermore, among immigrants, there was a lower perceived risk for TB, and also the fact that they might return to the country of origin within the foreseeable future was a barrier for the uptake of tuberculosis preventive treatments. Furthermore, we identified the use of professional interpreters and committed and supportive TB care staff as important facilitators for uptake and completion of the treatments. We also looked at the effectiveness of the TBI screening and TBI screening to identify persons with prevalent TB disease at the time of the screening. We identified or diagnosed 8 persons with tuberculosis disease. We matched the TB endpoint data to data from the National TB Register with a follow-up period of on average 2 years, and identified that there were 3 incident TB patients among the cohort that tested negative by IGRA. These patients were identified through a contact investigation, had a normal chest X-ray at entry in the Netherlands, and had a direct epidemiological link to the source patients. Hence, we hypothesize and can conclude that these patients were likely infected with tuberculosis after the LTBI screening, and they were truly had a true negative IGRA at the time of screening. Furthermore, we potentially missed 1 patient. This person was identified with TB disease after the LTBI screening, but was also lost to follow-up immediately after the screening before this person could be seen by the TB physician. Furthermore, we also identified 1 patient that had a positive IGRA, positive LTBI diagnosis, and also initiated and completed TPT. However, this person retrospectively reported an enlarged lymph node in the groin and had probably already had TB disease at baseline. So, no TB patients with negative IGRA were identified during our follow-up screening. We had a high extrapulmonary TB prevalence in our study, and this may be an additional benefit of the TBI screening because early diagnosis of ETBE or extrapulmonary TB may improve health outcomes for the individual patients. Furthermore, potential TBI screening has the potential to replace the current chest X-ray screening, but there's a lack of studies which include a follow-up period after the TBI screening program and also include epidemiological data. Therefore, we recommend that programs include monitor and evaluation components on the effectiveness of the TBI screening program to identify persons with TB disease. For the cost effectiveness, we employed a deterministic cohort model for which we based assumptions on empirical data. We also included an immigration component and a TB stage-specific sensitivity and specificity for TB diagnostics. Furthermore, we collected costs from a healthcare perspective and we discounted cost and health with 3%. We reported the outcome as the incremental cost effectiveness ratio, costs per quality gained. The cost effectiveness for the immigrants show that the TBI screening compared to the current chest X-ray screening policy is only cost effective for immigrants coming from countries with a TB incidence more than 200 per 100,000. And this can be explained by the fact that those immigrants are not only targeted for TB entry screening, but also for TB follow-up screening. So the TBI screening replaces both TB entry and TB follow-up screening and hence is cost effectiveness. Whereas in the groups with a lower TB incidence or coming from countries with a lower TB incidence, this is not the case. The TBI screening would only replace chest X-ray entry screening. In these groups, LTBI screening was not found cost effective. Among asylum seekers, we found that TBI screening compared to the current chest X-ray follow-up screening is dominant, or in other words, it's cost saving. When looking at the ages on the right pane of your of the presentation, we can see that for all age groups, the TBI screening is dominant. Furthermore, we also assessed the cost effectiveness of the settled migrants and identified that TBI community screening compared to no community screening was not cost effective. For the impact, we found that the impact of TBI screening on the annual or on the TB incidence in the Netherlands is most in the first 5 years after the screening. However, when you look at the trend over a period of time of 20 years, we see that the impact of TBI screening compared to chest X-ray screening is limited. And this can be explained by the fact that there is a large reservoir of migrants living in the Netherlands that are latently infected with TB and might reactivate later in life. We see in the annual numbers, the epidemiological data, we see that about 52% of all migrants developing TB in the Netherlands or diagnosed with TB in the Netherlands lived in the Netherlands for more than 5 years and likely reactivated their latent infection here in the Netherlands. So concluding, TBI screening is practically feasible if culturally and linguistically sensitive education is provided. Committed and supported TB care staff are in place, and client-centered TB support is provided by TB nurses. The population of interest for the TBI screening from this study are immigrants and asylum seekers from high TB incidence countries of all ages. And TBI screening, we showed that TBI screening has the potential to replace the current chest X-ray screening, as we did not identify any persons with TB disease that had a false negative TBI screening result. Points for discussion. For other high TB risk migrants, should we not screen them for TBI? Well, the current chest X-ray screening is also not cost effective. So the question for policymakers is, what is the willingness to pay to protect the public health? And also, what is the willingness to pay to work towards pre-elimination of tuberculosis in the Netherlands? Furthermore, should we limit TBI screening for certain age groups? From the proportion of migrants 35 years and older, that proportion is very small. So the question for policymakers is, would you like to implement two different policies for screening, or would you combine? An argument for not screening migrants older than 35 years is that there is higher risk of side effects from tuberculosis preventive treatment. However, if tuberculosis preventive treatment is not provided, then there still might be a value of awareness, being aware that you are latently infected, and if you might develop a chronic disease that is a risk factor for reactivation, that could be very valuable. Furthermore, also the eligibility of TPT should take place individually by the TB physician rather than in a policy as a whole. These are factors that should be taken into consideration by policymakers when making decisions on the policy for LTBI screening. Another discussion point is the eligibility for TPT dependent on the duration of stay in the host country. The thought is that people that would only stay in the Netherlands for a shorter period of time and would move back to the country of origin with a high TB incidence have a high risk of reinfecting in the country of origin, and therefore TPT might not be beneficial for these people. However, we also have a moral and financial obligation to contribute to the global fight against TB. And the question is, the chance of reinfection, is that similar, for example, among highly educated expat versus the general population in high TB incidence countries? This was my presentation. Thank you so much for joining this symposium. And I would like to hand over the floor to the next speakers.
Thank you very much, Ineke, for this very nice summary and overview of all the work that you have done during your PhD. You're well within time, so we will continue immediately with the next speakers. That's two persons who also have been involved in the TB Endpoint project. Janine Suurmond, she's working here at the Amsterdam UMC, a qualitative researcher, and David Tesfaye Haile, he was the research assistant in the pilots of the TB Endpoint project, so also had a very important role. And I just learned that now he's also a PhD candidate. So I guess you liked what you saw. Okay, well, the floor is yours.
Yeah, thank you. Good afternoon, everybody. My name is David Tesfay Haile. I'm here together with Janine Surmont to present our case. I had a chance to be part of the TB Endpoint project under supervision of Ineke and Janine. And today we are here to make a case with the following title. Participatory health research, a key for equity in care. The main thesis of our argument goes as follows. Participatory health research through a meaningful cultural sensitive engagement is a key for equity in care and preventive health interventions. The question, of course, is what do we mean by participatory health research? Who should be participated in our research? How do we make sure that we create a platform, a suitable platform for participation? And eventually, for what end? What do we aim to achieve with participatory health research? In this case, we look at participatory health research in two aspects. Participation in designing the research, but also participation in research in practice. When we talk about participation in designing a research, the question becomes, how do we make sure that we have a research design, we co-design a research with our research participants, with research groups that our research has an impact and intervention. The question of participation in research design is not only an ethical question, but also a practical one. For example, is our research need-based? Or when approaching a research group, are we approaching in a culture-sensitive way? These are the kind of questions that we ask when we talk about research in design. A recent publication which highlights what participation in research design, what we can achieve with participation in research design, explains it this way. To maximize the participation of those whose lives or work is subject to the research in all stages of the research process, including the formulation of the research question, the aim, the development of the research design, and the selection of the appropriate methods of data collection and analysis. The other aspect of participation is participation in research as practice. Here, the question is when we conduct the research on the ground. This is also the first time that our research, a well-designed research on paper, comes on the floor, and we have the first reality check when we approach our research participants. Then the question here is our research in practice? When we talk about culture-sensitive engagement in practice, we are talking about if our research group, when we deal with research groups that have a different conception of health or a different conception of care, or with research groups that has other needs or other priorities. In other words, a meaningful participation in research practice helps us to accommodate vulnerabilities, uncertainties linked to migrants' unstable position in society, but also to deal with the impact of migration regimes in the overall well-being of the migrants. To make sure that our research embraces a meaningful participatory practice and design, we may look at concrete interventions that may help us facilitate culture-sensitive engagement with our research groups. And here we list a few out of the many interventions that can be in place. One is, for example, intercultural mediation, rather than translation, a mechanical translation of a language or textual information. The other could be experts in the field with the desired knowledge and background of the research group. And the third one we say is taking off your Eurocentric lens in a way, because for a culture sensitive engagement, it requires to understand that your research group may have a different conception of health and care. And that way you make sure that your engagement becomes on a mutual respect and equality instead of an imposition. With that, I would like to invite to Janine to link this discussion to the equity and why it is relevant. Thank you.
Thank you so much, David. Good afternoon to all of you. I'm going to argue that we cannot do research without doing participatory research. I will explain this by starting with the inverse care law. This states that availability of good medical care needs to vary inversely with the needs of the population served. In other words, those who are most in need of medical care receive the least and the lowest quality of care. This is generally linked with wealth. Richer people have the lowest burden of disease due to the nutritional, environmental, and educational advantages, but have the best access to high quality care throughout their lives. Today, no fields are probably more aware of the relevance of the inverse care law than global and public health. To give a topical example, in the COVID-19 pandemic, migrants and refugees are among those most at risk of contracting a COVID-19 infection. Recent research at our department at the Amsterdam UMC found that migrants and refugees' awareness and knowledge of COVID-19 and COVID-19 preventive measures was shaped by factors like limited Dutch proficiency, limited access to understandable information, interference of misinformation, which all hindering the uptake of preventive behavior. Likewise, the research of Ineke Spruit showed that asylum seekers and refugees had often limited knowledge about latent tuberculosis. Language barriers, stigma, limited access to understandable information all may make the uptake of LTBI screening and treatment more difficult. But as Ineke's research also shows, the inverse care law is not a rigid, inevitable rule. It can be bent. It can be bent only with doing participatory research, as I will argue. First to the apple tree. Most of you will be familiar with the apple tree. In the first image, there is inequality. In the second image, it is assumed that everyone will benefit from the same supports, for example, the same healthcare. In the third image, individuals are given different support to make it possible for them to have equal access to healthcare. For example, by providing interpretation services for them to cross linguistic barriers. Together with Eritrean communities, this is exactly what Ineke and also David achieved through targeted action. Culturally tailored interventions were developed to provide communities with useful knowledge and awareness tailored to their needs. In the fourth image, all can pick apples because the cause of the inequity was addressed. Systemic barrier has been removed. This is also what Ineke did, offering equal access to tools and opportunities by offering opportunities to Eritrean communities to participate in the research, and by offering them opportunities to share their ideas about how LTBI screening should take place. To finish my argument, even though a participatory approach may not be cost effective, in my eyes, it is fundamental to reach equity and social justice. Equitable engagement of partners throughout the whole research process, from problem definition through data collection, analysis, to dissemination and use of findings, as David argued, will help to effect change. Community-based participatory research may address distributive justice, for example, to reach equal access to care, but also procedural justice, for example, fairness in how decision-making processes takes place. How does participatory research contribute to equity and social justice? In view of the time, I cannot go into detail now, but here are some examples, and I will use the model of Wallerstein to broadly describe the added value of it. using participatory research, important community knowledge, for example, about disease or about treatments that previously was ignored can now be taken into account. Also, co-creation between researchers and community stakeholders can lead to empowerment. And by involving communities into the research, culture sensitive interventions, but also new policies may be developed. So not only to meet the needs of majority populations, but also meet the care needs of vulnerable minority groups as well. Subsequently, this will lead to sustainable and long-term relationships and synergies between researchers and communities. For example, for future research and future appropriate research designs that really meets the needs of vulnerable communities. This way we can reach truly health equity and good health for all. I will end with the words of the WHO, which said everyone with TB should have access to the innovative tools and services they need for rapid diagnosis, treatment and care. This is a matter of social justice, says WHO. And I want to add, and it's also a matter of participatory research. Thank you.
Thank you very much, David and Janine, for pointing out how important this topic is, that many migrants are vulnerable and that it is essential to include them in the research, not just as study participants, as maybe we often do, but also as participants in an equal participants in the entire research process. And I think you state them as arguments, and I think they've been pretty much convincing. I would like to move on to our next speaker, who was for a long time with the World Health Organization, amongst others working on screening, both screening for tuberculosis disease and tuberculosis infection. And for a couple of years now is a professor at Karolinska Institute in Stockholm, Sweden. Knut Lönnroth, he will be talking about evaluation of the coverage and cost effectiveness of TB infection screening for asylum seekers in Stockholm. Knut, take it away.
Thank you, Frank. Can I just check first that you see the right version of my slideshow, the audience view?
I think we see your own presentation, your own presentation view. So you have to click on the top.
I'm trying to swap.
Yeah.
How about now?
Yeah, this is the one.
Okay, thanks, Frank, and thanks to KNCV for inviting me to share some of the findings from this project that has been going on since 2015. Actually, it's a very similar project to TB Endpoint in that it's evaluating the cascade of care, and it also includes a cost effectiveness modeling. Those are the things I will present here. It has a number of other aspects, including some qualitative work with interviews of asylum seekers, of healthcare policymakers, and of healthcare staff that I will not cover in this presentation. I cannot say that it has been as participatory as the TB Endpoint project, and one reason for that is that this project is not assessing an intervention. It is assessing something that has been in place actually for decades in Sweden. So the kind of screening approach, starting with an IGRA, has been in place in Sweden, I think, longer than most other countries. So it's very similar evaluation of something that is similar to what has been done within TB Endpoint, but this has been policy for quite some time in Sweden. I'll first take you through what that policy actually has been. So since the 1990s, with some tweaks along the way, there's been this model of inviting all asylum seekers. And there's another difference from the TB Endpoint. This only looks at asylum seekers because those are the only migrants that are being targeted within this policy. They're invited to health examination, which is not only for TB, it's supposed to cover all health aspects, but within that there is TB screening. For all asylum seekers, there's symptom screening, and for all coming from a country with an incidence of more than 100 per 100,000, IGRA is being offered. Also, those that have a history of being in a refugee camp or imprisoned along the migration route or any other clear exposures, there is also a recommendation to do an IGRA. Chest X-rays then offered if IGRA is positive, or of course if there is symptoms. Now, if active TB is ruled out, then comes the question of putting people on TB preventive treatment. a bit different from the TB endpoint project is that the eligibility for treatment for latent infection is rather strict. And actually, Stockholm has been stricter than other regions in Sweden. So first of all, the IGRA needs to be positive, X-ray negative, but then it was decided a couple of years before this project started to only do systematically invitation to treatment for those below the 20 years of age. If older than 20, then it's a clinical decision based on presence of risk factors. So here, it's not for all, but it's a selected group that is supposed to be eligible for treatment. Now, coming into this project, what we didn't know was, first of all, there has been no evaluation of this screening program, although it had been in place for such a long time. There were some indications, or I should say guesses, that it was low coverage. There were some numbers circulating that probably less than 50% of the asylum seekers attended this voluntary health examination. And there was a lot of discussions about how to improve that coverage. There had been one study published on the treatment completion, which was quite low in special migrant groups. But after that, there had been some interventions to improve health education and to motivate patients and to provide more treatment support, quite a lot along the lines that have been presented from TB endpoint. So what we wanted to do, and what I'll describe here, is first of all to look at the cascade of care, look at the completion of the health examination, the screening, and then being put on treatment and completed treatment. And then we did a cost effectiveness modeling of this. Very briefly on the methods, the cohort that we created was using mainly record data, and we did record linkage based on personal IDs, temporary personal IDs in the case of asylum seekers. So matching the Swedish Migration Agency registry, this was to get the denominator of who was supposed to get a health examination and screening. And then we extracted automatically from electronic medical records. And this was both for primary care and then for specialist care to see who went on to being referred to specialist care and who was put on treatment and finalized treatment. Some of the aspects of the decision-making was not possible to get from an automated data extraction. So we had to do some manual record reviews, and we did this for a subset of this cohort during 2 years in 2016 and 17. The data for the cost effectiveness modeling, very, very briefly, we used this cohort data. So it was a model exactly the same as for TB endpoint, using the cohort data that we had generated, cost data from the Public Health Agency and from the healthcare providers. We also did surveys to get health-related quality of life to plug into the model, because quality adjusted life years was the outcome. We used some transmission estimates based on the Public Health Agency data and their whole genome sequencing. And then we used systematic review data for some of the parameters that were plugged into the model. I'm not going to walk you through this. This is just showing the complexity of the cascade that we tried to capture in some of the registers being used here and linked by ID numbers. So it goes from being an asylum seeker, going into primary care where the health examination is done, being referred to the specialist clinic, and then from there getting the data on the treatment outcome. This little box here, can you see where I'm pointing? By the way, I'll probably take this laser pointer. Sorry. Wrong one here. We tanked all this data into UCL database because this was part of the eDetect TB project, along with Netherlands and Italy and England. All right, moving on. First, I'll show you some snippets of data here. This is the coverage. So the proportion going for a health examination by sex, age, and incidence in the country of origin. So we had, on average, about 70% of those eligible going for a health examination, and the pre-study estimate was below 50%. So it was better than that, but of course there is still a gap. It was slightly larger for female. It was slightly larger gap for those above 35 years of age. Those that were a bit younger had usually a guardian helping them through the asylum process and informing them about this health examination. There were more men, especially young men among them, which probably explains that men had a bit higher coverage rate here. The explanation for the remaining gap, and this come out of the qualitative studies, has to do a lot with the information flow. What kind of information was being given to the asylum seekers, what the nature of that information was it appropriate language, did they get the meaning of this health examination? So we concluded that this had little to do with asylum seekers not being willing to come to the health examination, but more with how to get the information across. IGRA positivity is shown here. Quite similar to the Netherlands data for the group of asylum seekers, around 20% for the whole group. No big difference between men and women. The expected increase by age and expected increase for people coming from countries with a higher incidence, except we did not see this progression for countries with a higher incidence than 300 per 100,000, which we cannot really explain, but it was not. There were few countries and also quite few coming from those, so we shouldn't draw too many conclusions from that. Here's the cascade of care. So among those, we had 5,470 people being screened by IGRA entering to the analysis where all the data was available. And among them, then 25% were positive, and we have 1,364 IGRA positives. Now, if you look at the cascade of care, we can see that 56% were never referred to a specialist care for assessment of the eligibility. So it means the pre-assessment that these persons were not eligible for treatment. Those that were sent to a specialist clinic, among them, 85% were actually visiting, where there was a slight dropout here of 50% not going. Among those visiting the clinic, 70% initiated treatment and 30% did not. If we stop at this point here, of those that had treatment initiated, so you see that the percentage is always the percentage of the box above. So in total, it's 26% of the IGRA positives that were initiated to treatment. And the main explanation for this is here, that physicians did not refer, and this is actually by policy. So what I described before, that if you're above 20, you had to have special criteria. So this is the main driver, not that patients were unwilling. The next part is here, those 30% that did not actually start treatment. And for that, we did this special manual review of the reasons for that. And I'll just summarize that briefly in the next slide. So this is a subset, the numbers are therefore slightly different. But if among those visiting a clinic, a specialist clinic, 31% were not put on treatment. So again, this was this decision not recommended treatment by the physician. Among those that were recommended treatment, 97% started treatment. So there was a small dropout only of patients who did not want to have treatment. And among those starting treatment, 91 completed it, and half of those that did not had adverse drug reactions. So we concluded that the attrition again was mainly due to physicians' decisions that this was a person not eligible for treatment. And the main drivers here were age and also women more likely, because quite a few of them were pregnant. And that was one of the criteria, one of the risk factors being listed as an eligibility. Very briefly on the cost effectiveness, here is the cost per QALY in Swedish krona. So each bar here is an age group, and we did this by age because the results were driven a lot by IGRA positivity and eligibility for treatment, and both those are determined by age. The lines here are the Swedish cost effectiveness thresholds generally used, and this is in Swedish krona. If you divide it by 10, you get it in euro. So what we found was that in the youngest age group, it was not cost effective. In the adolescents, it was moderately cost effective. So the explanation here at both these groups all are eligible for treatment, but IGRA positivity is higher among the adolescents. Moving to the 18 to 34-year group, this was only if you had risk factors that you were supposed to get treatment. So few were treated. IGRA positivity was higher, but that did not compensate. And when we get over 35 and above, then it's definitely not cost effective. There is actually a bar for 55 up, and that goes through the roof, so I'm not showing it here. So this group, here, no question asked. This group here, policy decision after this study was to continue the screening because they are kids and different thresholds apply. This group is the controversial one and difficult one. I'll say a few words about that. And this group were not supposed to be screened with IGRA after this study was done. Unpacking this age group 18 to 35, we ran a scenario analysis here saying that, well, what if we put not all of them, but most of them on treatment? What would be the cost effectiveness? And then we found that if you extend the eligibility criteria, you get into this zone of moderately cost effective. If you break it up further and only focus on those coming from countries with an incidence of more than 200 per 100,000, it's slightly better, but it doesn't reach the very cost-effective threshold. Now, the policy is to continue to screen in this group and to broaden the eligibility criteria for treatment rather than not screening them. So to summarize, important point is that we did not find that it was the asylum seekers that caused the gaps in the implementation. Rather, it was the physician's decisions, and the physician's decision were rational because they were based on the policy. We found that it was moderately cost effective for those that were eligible for preventive treatment. It was not so for the kids, but as I said, it was still acceptable level. If you screen people who are not eligible for treatment, and this is sort of a no-brainer, then it doesn't become cost effective. What we found, and I haven't shown this data, is that most of the effectiveness came from, almost all of it came from preventing reactivation, and very little came from early detection of active TB. I didn't mention there were only 10 active cases detected during 4 years. So we conclude also that it's not very cost effective for using only X-ray to screen for active TB. Although this is actually now the new policy. If you're over 35, X-ray is the entry point for the screening, and no IGRA is being used unless you have special risk factors for progression. Final slide is just the list of publications coming out of this. And I don't know if we share the slides that people can dig into the details. Thank you.
Thank you very much, Knut. Very interesting presentation, nice overview, and also very interesting to see that in broad lines, the results are very similar to what we found here in the Netherlands. So thank you very much for joining from Sweden. We now move to England. Dominic Zenner, he's an infectious disease epidemiologist, very well known also in the field of TB. He has helped to develop has helped to develop and implement the TB strategy for England, including on LTBI screening and pre-entry screening for migrants. So, and he's here to share with us the challenges and successes. Thank you very much, Dominic. The floor is yours.
Thank you very much. First of all, can you hear me?
Yes.
Yes, fantastic. And you can see my slides. Good. Thank you very much for the warm introduction and for the invitation. I will probably not say very much new, except that I will contextualize all that was said in the British context. So you will find that whilst I take you through this whistle-stop tour of different aspects of TB prevention and screening in the UK and England, that it tallies quite well with what you heard from the Netherlands and from Sweden. So first of all, I'm going to talk you through the epidemiology of TB in the UK. You can see here in England the numbers and the rates of TB. It peaked around 2011-12, and from then it basically came down, largely driven, and I'll come back to that, by interventions. You see on the right-hand side, this stratifies the cases and the incidence by UK-born and non-UK-born individuals, and you can see that this is largely driven by the non-UK-born cases. So keeping that in mind. So a very brief slide on TB policy in England. You may have heard about the collaborative tuberculosis strategy for England, which was between 2015 and 2020. I should say that basically from sort of 10, 11 onwards, basically things were implemented. So keep that in mind when we're looking at the numbers. And now, of course, this has been superseded by the TB Action Plan for England 21 through 26, which largely fleshes out and takes a number of those items across. And you can see the items or the chapters of the strategy on the left-hand side, amongst which to point out maybe just 3 is, of course, improving access and diagnosis and doing awareness raising and things like that. Tackling TB in underserved populations, which is quite important. And of course, the latent TB screening program for England. What is not on there, but also equally important, is the pre-entry screening in England. So if you map it out, so this is basically just mapping out the migrant prevention and screening interventions that you can see. So this is taken from Lewis's paper in 2019. You can see that there is pre-entry active tuberculosis screening. I've got a slide on that. There is post-entry latent tuberculosis infection screening. There are other things that play a role, like health surcharge and things like that. And there are other opportunities which are largely also being looked at, like health promotion, enhancing GP registration, etc. It's quite important to keep in mind that in the UK, we have a GP-based system, and the healthcare system hinges on GPs having the keys to being the key holders for the rest of the health service. And so this is very much a GP-driven system, just to keep that in mind when you're listening what else I have to say. So the UK pre-entry screening then is a mandatory chest X-ray-based active TB screening in the country of origin for all people that are applying for a visa longer than 6 months, if they're coming from countries with the TB incidence greater than 40 per 100,000. We've got 101 countries for which a screening is currently taking place. And on the right-hand side, you see a figure taken from the annual TB report, which shows the number of pulmonary TB cases. This is only screening for pulmonary TB that were diagnosed with TB screening, that is in green, and in red, those people that were also notified to the domestic surveillance system, which were also within 1 year of entry. And you can see that this is largely screening prevalent cases, and it's screening most of them, but of course it's not tackling reactivation cases later on. Then there is also a latent TB testing program for migrants in England. This is a fully funded program and is part of the national strategy, and it's valid since 2015. It's running with some dips, I should say, during the COVID pandemic. And the eligibility criteria, this is an IGRA-based screening program. Eligibility criteria are from a very high TB incidence country, more than 150 per 100,000, or sub-Saharan Africa, who entered the UK within the last 5 years, and if they were aged between 16 to 35 years. It's written there. So how's that going? Well, there are ups and downs. So we screened quite a number of people, as you can see. These are the number of tests. Test positivity, I didn't put it there, varies between 15 and 20%, thereabouts. But you can see on the right-hand side, I put some quotes from the annual report, and I thought this is quite stark. So the treatment outcomes were available for 35% of those with a positive LTBI tests. And that it means there is a problem in surveillance, of course. The percentage of people with positive test results who are known to access treatment across England was low, 67%, and has declined even to by barely 40% in 2019. And many factors for that, we'll come back to that. But the national treatment completion rates were reasonable, and so they're standing at 81% at the moment. I don't need to remind any of you of the seminal paper from Hannah Alstoff, which actually maps out the leaks to screening, Here we've got intended for screening 100% and completed treatment at barely 19%, and that there are a number of reasons for that, also quite well described. There is also some evidence what works. And you can look at the patient level and at the provider level, and they're both very important. And again, I'll come back to that too. So obviously things that we know, IGRA is probably better than TST in terms of the treatment cascade. Shorter regimens are incredibly helpful. Directly observed therapy, even for TBI, may be helpful. And then there's a range of different social interventions, such as adherence coaching, cultural interventions, and all the rest of it. I wanted to sort of continue where my predecessors left off and talk about the role of providers, which again in England we found very, very important. So here you're looking at a study, a cohort study from which was in the Newham pilot. Newham is a place in London for the LTBI screening, and you see that obviously this goes up to treatment uptake, the cascade of care, and the treatment uptake varied between 37.5% and 58.5%. There weren't any demographic and clinical factors that were significantly associated. So corroborating Knut's point that actually this wasn't the patient's fault, really, it didn't seem. But the treatment uptake varied by GP surgery very dramatically between 0 and 100% of LTBI cases taking up treatment. And in fact, that was the major point that actually determined uptake of LTBI treatment. So what are we doing with all of that? Well, I think it's important to target at different levels. So providing guidance and information. This is our famous toolkit that we provided to the to providers mainly and to commissioners to map out the pathway. What can be done at each individual step of the patient's pathway, promoting, identifying, inviting, informing about the test, etc. There's also commissioning guidance that we brought out, and some of that may entail incentives, so to enhance, to give some financial incentives for screening, for example. Equally, it's important to have patient-facing materials. I talked in the past about the animation videos that we did, and here I've just exemplary put a leaflet that we put out in various different languages to the patients. Let's stop and think. When implementing TBI screening, let's think about the patient and the population, the healthcare provider, the setting, the circumstances, knowing what goes on and everything else. Well, thinking about this, we started on a broad-based portfolio of community-based research. We wanted to know more about what people believe, how we can change that, what's the best setting for doing that, who are the best people to reach out, and what to do about stigma, things like that. So here's an example of a study that we ran. So this is a qualitative study, interviews and focus groups together with participants from NGOs, from community-based organizations, statutory organizations, and patients in London. And we wanted to know from them what's the best place and what's the best way of reaching out. So what are the interventions that facilitate collaboration to improve healthcare outreach and delivery amongst migrants, with a particular focus also on how different organizations interface. We identified broad topic areas: capacity, collaboration, culture, and trust. We haven't got time, unfortunately, to go through all of them, but you see them on the right-hand side. I can share the slide afterwards. But basically, the sum total was that it came out quite clearly that community-based organizations, statutory sector, NGOs, they all have a role to play and have different complementary skills and roles, and we sometimes ignore this interplay. Fitting services around user needs is crucial. That's often better by community-based organizations. Different timelines and expectations for different organizational cultures can create conflict. That's particularly the case between NGOs and the NHS, perhaps. And fear and trust plays a major role in healthcare access. So, you know, migrants do have their own agenda very often: fear of deportation, stigma of disease, and all the rest of it. I also wanted to point out the Catapult trial. So this is a trial we just concluded, actually, treatment of latent tuberculosis infection in primary versus secondary care. That was a cluster randomized controlled trial in East London. We wanted to find out what is the efficacy and safety of primary care-based model of care to treat migrants, or to treat LTBI amongst recent migrants to the UK. And the important thing there to know is that basically normally TB is treated in secondary care, of course, and so is LTBI. The conclusion was that the treatment of LTBI in recent migrants within primary care is effective, safe, and costs less, and but fewer patients accept treatment when compared to secondary care, corroborating some of the earlier findings that actually it's quite important to work with providers on those kind of things. There's also something to say about combining testing for multiple infections. There's a current study, the Combat ID study, which runs and looks at combining different infection screening, but you could also put into the mix things like diabetes screening, often opportunistic, using care access, holistic, feasible, practical, acceptable, and is likely associated with higher uptake rates. I looked today, unfortunately, they haven't reported yet, but I expect that's going to be reported hopefully very soon. And especially for people that are highly vulnerable, where, for example, for homeless populations or things like that, that might be the way forward. Just a slide to emphasize the importance of monitoring in LTBI screening. We all have that implicit, and to emphasize that basically the clinical standards for lung health have been launched, and there will be a chapter, I should say, or a paper on standards for LTBI care, and those monitoring markers will be part of that as well. I wanted to conclude on a couple of positive notes as well. So when you saw, and you remember, I'm going back to the incidence curve in England, that basically the number of cases and the number of the number of new cases and the number of the rate of new infections has decreased overall. So we looked at that in detail, and we found that the incidence rate ratios fell primarily in non-EU migrant and UK-born populations. The greatest decrease was amongst recent non-EU migrants. And that's not explained by border policies. So that would lead to a reduction in cases, but less so in rates. But 61.9% of the reduction of TB notifications was attributable to decreases in rates. And about 1/3 was due to a fall in the number of recent midterm non-EU migrants. 11.5% is due to pre-entry screening. So it's many of those factors that actually have led to quite a sustained and quite a large reduction of TB rates and cases. I also wanted to point out this study because we need to take it further. So this study is a unique study which looks at both or at a combined effect of pre-entry screening, post-entry latent TB screening, as well as things like GP registration and other markers for healthcare, basically. And they, we conclude that the evidence of a positive association between pre-entry active tuberculosis and post-entry LTBI screening programs was there, and a reduced incidence of tuberculosis and that reduced the incidence of tuberculosis in new entrant migrants to the UK. So that's good. But it goes further. It also demonstrated low levels of primary care registration in migrants from countries with a high incidence of tuberculosis. So that's not good. And there was an association between the delayed access to primary care and the risk of developing active tuberculosis, remembering that primary care really is the entry point to the NHS. I know that it's perhaps a little bit hard to see, but you can see that corroborated in this regression analysis for where the outcome is active TB cases. And you can see that those that have no pre-entry screen or LTBI screen in the multivariate analysis were much higher, much more likely to have to result in a case. And the time from arrival to in the UK to primary care registration was also is also highly significant. So those that registered more than a year after coming to the country had 3 times the risk of TB. So I conclude with a summary slide that TB prevention and screening in the UK is ongoing with some success stories. So we're doing pre-entry screening for active TB, post-entry screening for LTBI, multiple interacting activities for health promotion and awareness raising are also there. The key to success or failure is the practical implementation at population level and provider level. It's key to tailor the programs to the population, making it easy, support signposting, having accessible, familiar settings. There might be merit in combining the screening and disease programs. Providing provider training and education are very important, and it's an iterative process which one needs to monitor very carefully. Thank you very much for your attention. Thank you.
Thank you very much, Dominic, for this great overview of what's going on in England and particularly in London around this theme. And I thought it was also an impressive range of studies that you showed in which evidence is being gathered. And I think it's also a lot of experience that you've shared with us, so very important. So thank you very much for that. And thank you for joining us from all the way from London. It's now my pleasure to introduce someone who in the TB field doesn't actually need any introduction. He was for many years, I always forget how long, Mario, but I think maybe somewhere between 10 and 20 years was heading the... 15 years, there you go. 15 right. Years heading the tuberculosis department, later the global TB department at the World Health Organization in Geneva, and is now leading the institute, the Global Health Institute of the University of Milan in Italy. Mario, we are very pleased to have you here. You're going to talk to us about the global health challenge of migration and tuberculosis and the Italian experience. Mario, the floor is yours.
Thank you so much, Frank, for this welcome, and I'm equally very happy to be part of every once in a while of the TB community, right? That I belong to. You see the screen, right? I can go ahead, correct?
Yes.
Very good. All right, so what I'm going to do is actually 2 things. One is general understanding about why migration is so important within global health. And I will be then speaking about the strategies at more or less high level, so global level type of thing, and then look into what has been done in Italy, in Milan in particular. So let me just define global health for those who are not in this field, like Frank and I are nowadays. Global health is an area for study, research, and practice that places a priority on achieving equity in health for all people worldwide. It emphasizes transnational, as you see, there are health issues, determinants, and solutions. Therefore, migration is central to this. It involves many disciplines within and beyond the health sciences. It promotes interdisciplinary collaboration. We will never solve the issue of migration just within health, and is a synthesis of a population-based prevention modality with individual level clinical care. The keywords in global health are those that I listed there. So access, equity, multidisciplinarity, cross-sectoriality, sustainability, and if you like, ecological considerations for the planet. That's what global health is. So you see how central migration and health of migrants would be in global health. Now, this is just to show very quickly, the world today is, or rather this year has had something in the range of 281 million migrants. And of those, 87 million are in Europe, the majority in the world. And as you see, there has been quite an increase between the early 90s to the 2020s. This is a study that Andrei Dadu from WHO gave me a few years ago that I just use here to reiterate the importance of tuberculosis in migrants. And you see it was done in the Netherlands with all the TB cases that emerged among migrants, among foreign-born. And what you see there is that if those of those rather that would develop tuberculosis, the majority, more than half, would do it during the first few years after migration. And that is a well-known phenomenon. Now, looking at TB by foreign-born status, you see that kind of trend in the European continent. You see, in fact, this is the European Union. And what you see there is the percentage of foreign cases. The logarithmic scale on the left is quite significantly on the increase. We have today 34.5%, the latest data among foreign-born in Europe. And you see in red there, rather, the cases per 100,000. So the rate has remained roughly stable. It's between 3.4 and 3.7. And this is the map that you can compile. On the left is the latest one I found in 2018 from ECDC. And what impresses you is the fact that the majority of Western European countries, the vast majority, have a percentage or a proportion of cases among the foreign-born that exceeds 50%. And at the center there, you have the latest data from 2019. What they say is this, just not to go into any detail, but of nearly 50,000 cases in the European Union, you have 2/3 among natives, which means 34.5% among the foreign-born. And you have, in the case of Italy, 56%, and in the case of the Netherlands, 75%. And there are a few countries listed there, like Sweden, for example, that have more than 80% of the cases among the foreign-born. So let's look at the strategies to face this challenge. Well, the first one I want to allude to is the NTB strategy that was developed with in mind the context of the Sustainable Development Goals and what they mean, which are effectively the same principles for what concerns health that I announced at the very beginning when I spoke about global health. We all know about the End TB strategy by now, but let me highlight the fact that among the principles of the NTB strategy, we were speaking about protecting and promoting human rights, ethics, and equity. And that has a meaning when we speak about migrant health. We then were speaking about bold policies and supportive systems, so important for TB control. And finally, of integrated patient-centered TB care. These are, and prevention, of course. These are all, I would say, keywords when it comes to tuberculosis in migrants. Not only, but when you look at the actual resolution that promoted the NTB strategy and the related targets, this is the wording that we had there, guided by a previous resolution on the health of migrants and its appeal for action and recognizing the need for increased collaboration between high and low incidence countries and regions in strengthening TB monitoring, etc., including with regard to the growing mobility of labor. Not only, but in the request to the Director General, you have this wording, number 1 there at the bottom, provide guidance to member states on how to adapt and operationalize strategy, including promotion and cross-border collaboration to address the needs of vulnerable communities, including migrant populations. So no doubt that this has been policy. In 2014, we also issued this interesting couple of pages actually devoted to the problem of tuberculosis, the challenge, I should say, of tuberculosis prevention and care for migrants, together with the IOM, the International Office for Migration, where we spoke about migrant inclusive national TB plans, migrant sensitive care and prevention, bold intersectoral policies and systems, and operational research. All words that you have heard so far from my ex-colleague such as Knut in Sweden, or from Zenner in the UK, and from Ineke in the Netherlands. And then we were not happy enough, and so Knut Lönnroth actually was the coordinator of this work that we did immediately after the resolution on the new strategy, the priority actions for low incidence countries. And what you see there is this: number 3, address special needs of migrants and cross-border issues, and number 4, undertake active screening for both disease and infection. And when you look at number 3, that is devoted to specifically to migrants, undertake epidemiological assessment and surveillance, ensure universal access to culturally sensitive health services, including social support, establish cross-border collaboration and consider screening. Now, when you look at the WHO recommendation, these are the 2021 recommendation on screening, that is the systematic identification of people at risk in order to then intervene. Apart from what you see at the bottom there, household and close contact, people living with HIV, minors, prisoners, you have the following recommendation for populations also to be screened that was considered conditionally recommended. People with untreated fibrotic lesion, etc., and then populations with structural risk factors for TB and limited access to health care, which include obviously homeless, refugees, and migrants. So what about Italy? That's the situation of migration in Italy. So there was a peak in those years, 15, 16, 17, then a major reduction, and then again, a slight increase in 2021. And this is the situation in terms of trends of native versus foreign-born tuberculosis. So nowadays, 56% are among foreign-born. And as you see, there has been a downward trend in the past couple of years, probably linked to the fact that migrants were much less than in the past. When it comes to guidelines, well, there is a set of guidelines that was developed by the National Institute of Health in 2018. I happen to be, by the way, an external reviewer for this set of guidelines that follow the grade system and so on, where they then, together with two NGOs that work on migration and health, they outlined 5 areas for guidance: access, identification of disease, screening of infection, adherence to treatment, and vaccine. And this is what they say selectively on, for example, early diagnosis. They speak about health education campaigns among migrants. They speak about collecting the history of the patient at any early encounter with the patient. And in case of any suspicion, then what needs to be done, radiography, bacteriological test. And when it comes to screening of migrants, the guidelines emphasize that screening is recommended in everyone that is coming from countries above 100 per 100,000, that there is a preference for a sequential test, first TST, then in those positive IGRA, and the treatment that, of course, must be offered for people who are positive to both screening, if you like, and as I said before, treatment. Now, the Italian experience in the last few minutes, I think I still have a few minutes. This is what was presented, is the work of a research fellow who is working with me now. At the time, it was a thesis, his thesis. On the left was a poster presented in Nice, and on the right, you have the full reference that was published in the European Respiratory Journal. Now, Dr. Villa looked at the period 2016-2017 at the study location, obviously, that was the area surrounding Milan, the province of Milan. And this is the, let's call it the algorithmic approach, so to speak. So asylum seekers were tested with questionnaire and TST at the site where they were hosted. They would then undergo chest X-ray and further examinations for those who deserve those in a different place, Villa Marelli, which is the main TB dispensary, let's call it this way, in Milan. And this is the numbers that they found, essentially, that Dr. Villa described. Over 6,000 asylum seekers. Questionnaire were provided to more than 5,000. There was a drop there, obviously, because some meanwhile had gone. You have then the numbers of those with a positive TST or a relevant questionnaire that would undergo chest X-ray. That was essentially where the major attrition was, 41% lost. And the loss was linked to the fact that you had 2 different sites where to do these 2 types of interventions. Chest X-ray eventually was on 1,400, and you see the numbers of TB cases detected, 69, with a very good cure rate of 84%. Those who were negative at chest X-ray, but having latent infection or suspected latent infection, underwent IGRA. That is the number, and you see that there was a completion rate of 94%. So the conclusion of the studies are listed here. TB prevalence and disease, both of them were pretty high among asylum seekers in Milan. Transmission, I didn't speak about that. I don't have time, but there is a graph here that shows essentially the transmission was a very rare event. Within the system, the attrition was major, and it was due to two different sites where the screening was undertaken. First chest X-ray, first TST and questionnaire in one place, and then chest X-ray in another, and that is where the attrition is. Treatment success for TB was high, and adherence to latent infection treatment was equally very high. And we concluded that if you really care, good results are possible. We then became aware of the study by INECE and the study that was presented in essence, and we wrote a letter of, in a way, support to what was done in the Netherlands. We basically said that similarities are there in the burden, similarities are there in the good results. We spoke about the importance of social anthropological aspects that could actually increase compliance and everything you need for a shared EU-wide strategy to offer screening to asylum seekers, and we spoke about the dream of a single database, and here we can open a big question there related to migration and health, migration and TB, that would allow sharing of information. And these are my last conclusions that are obvious. TB among migrants, sorry for the among, is important in low incidence countries. Surveillance and screening are key to reduce interval suffering and protect the population. Access to care is essential, and this has to be migrant sensitive. And finally, once again, if one really cares, good results are in fact possible. Thank you very much. And best wishes to INECE, by the way.
Thank you very much, Mario, for this nice overview on the global health challenges of migration and also the Italian experience. Very interesting. We move on to the next speaker, Connie Erkens. She's a TB consultant at KNCVTuberculosisFoundation. She also was very much involved in the TB Endpoint project as a supervisor for INECE. And she will now wrap up and talk about all lessons learned and remaining gaps for the future.
Thank you very much, Suzanne. Yeah, good afternoon to you all. Of course, I'm very much honored that I am allowed to wrap up after all these eminent speakers who have reported for their experience from the different countries. Where's the and I don't see the right presentation yet, but here it is. Yeah. Okay, thanks. Now I'd like to start first with a little bit of history, because this TB Endpoint project presented by INECE was an implementation project in a series of research projects to improve the TB prevention among migrants, funded by the Dutch government through Zonneweg, which started already in 1998. And all these projects led to major policy changes. The first project, you can see on top in the left corner, led to a routine system for monitoring and evaluation of the migrant screening program. And the periodical evaluations that ensued have led to consecutive policy adjustments in the populations of migrants that are actually targeted for TB screening. That means that the number of migrants eligible for screening were reduced tremendously, but still the effectiveness of the screening remained the same. Then the following two projects showed the usefulness of testing for TB infection and TB preventive treatment, specifically with IGRA among the migrant contacts of infectious TB patients. Based on this evidence, TB contacts from endemic countries became eligible for TB infection screening and TB preventive treatment. And the effect of that you can see in the right corner in the graphic there, where you can see that the number of migrants with TB infection notified to the register in the Netherlands increased tremendously in the last 10 years. And the percentage of foreign-born among persons with TB infection increased from less than 20 in the early years of this century to more than 60% in 2019. Well, oh, sorry, I'm going too fast, but the TB Endpoint project was especially aimed to provide more evidence on to which other high-risk migrant groups it would be sensible to include in targeting for TBI screening and treatment. So what have we learned from TB Endpoint? The main findings of the TB Endpoint project, as already represented by Ineke, are summarized in this slide. I think the pilots have helped to build confidence among the professionals in the Netherlands that TB preventive treatment is feasible when offered under the right conditions. And that is involving the community for culture-sensitive messaging, and that will enhance their motivation and the acceptability of the intervention for the target population, as has been shown. The results do convey two potential barriers for further implementation, and that will need to be considered by the policymakers. Culture-sensitive health education, as has been discussed, needs to be given by dedicated and well-trained public health staff. And it is important that they discuss the risks and benefits of the intervention in person with each individual. And such a personalized approach is costly, and public health budgets are always limited, as we all know. In the Netherlands, the cost effectiveness is based on criteria for cost effectiveness published by the National Health Institute. And as Ineke has shown, both the current radiological TB screening and the TB infection screening are not cost effective according to these criteria. One can argue that the actual willingness to pay and for cost effectiveness of the current radiological screening at entry may be a better criterion to decide on cost effectiveness. But even if we do that, the data show that TB infection screening is more costly than the radiological screening, despite the higher health gains. And that means that investment costs for an implementation program for the wider, to reach wider migrant groups are likely to exceed the currently available budget. What we can learn from other cost effectiveness studies has been presented more or less also by the previous speakers, but I'll just mention a few highlights which I took from studies from the UK and Sweden. In the Swedish cost effectiveness study, they come to a slightly different conclusion than TB Endpoint. In Sweden, it shows that TB infection screening is cost effective in adolescents and young adults, and then especially from high incident countries. But as has been shown by Knut, in Sweden, the TB infection screening is a component of a more general health examination that may have influenced the cost for the program. This study from the UK was already published in 2013, but already showed cost effectiveness of TB infection screening in high-risk migrant populations. And I took this study because it illustrates the balance between the cost effectiveness and the impact of the intervention. the study group calculated the projected number of cases that would be prevented and against associated costs using different screening costs and different screening thresholds. And the study shows that, well, it's quite obvious, impact of this is best when you use a low threshold, and cost effectiveness is better with a high threshold. It was actually best, according to the authors, among those coming from countries with a TB incidences of more than 250 per 100,000 per year. But they favored the lower thresholds of 150 per 100,000 per year, as it averted more TB cases within still an acceptable cost effectiveness range. And this study here was done in preparation of the ECDC guidance for programmatic management of LTBI. And this leans mostly or for parts on this the study Dominic showed from Ellsberg, that showed that losses along the cascade of care are very much determining the effectiveness of the intervention and the possible impact that the intervention has on epidemiology. And we also saw the same in TB endpoint as the among the immigrants population. If we come to conclusions about from the comparison of these studies, it is actually very difficult to compare the cost effectiveness between the various programs in different settings, and given also that the different studies have used different mathematical models. A solution could be that to do these calculations again and compare the models with using the same country data, and then see what is the outcome, and perhaps that could give some conclusions on which model of care is preferable from a cost effectiveness point of view. But there is agreement on one point. The TB infection screening is cost effective in very high risk groups, and then also targeting only the high risk groups will not have enough impact on the TB epidemic, especially if you want to contribute to the TB elimination goal. So for more impact, it would be preferable to screen the largest possible population. But current tools have low predictive value for development of disease and are too costly in terms of finances and also for required human resources. So to reduce the program costs for reaching and educating the target population, costs of tests and infrastructure, we need to develop better predictive tests and make use of more effective preventive treatment regimens. There are options to bring down the costs. The first option is to combine TB infection testing, as Mario also suggested, and combine it with other disease programs. For instance, for COVID-19 testing or hepatitis, HIV testing, or even testing for non-communicable diseases. And this was recently also recommended, for instance, by the Stop TB partnership. That if you manage to do so, testing at a common site with or perhaps with a multi-disease testing platform will save costs for health staff, specimen transport, and also on a reporting system as well as facility costs. Other options to bring down costs are to study or explore the utility of new TB infection tests. And from this, I took these slides, these pictures from a presentation from FIND, showing what is in the pipeline. There are quite a number of new IGRA tests in the pipeline. Here you see 3 ELISA-based IGRA tests, but there are also 3 IGRA-based skin tests, and there are a number of IGRA lateral flow approaches, which are more or less promising because they don't require sophisticated laboratory equipment and can be used in local settings. So there can also be savings on expenditure for sample transport and perhaps also turnaround time. Even better would be if we can have tests that better predict the later onset of TB. And these, the mRNA signature tests are the most promising at the moment. The use of these tests would allow targeting the TB preventive treatment more accurately and thus reduce on the costs for unnecessary TB preventive treatment medication. The next steps for the Netherlands are implementation of TB screening and treatment in the target populations for follow-up screening for in these groups, as Ineke has shown, the implementation of TB infection screening would certainly be cost effective, and among asylum seekers even cost saving. But we also have to look at a group which was not really included in the TB endpoint project, because they're currently not really targeted for a follow-up screening, and those are the asylum seekers between 50 and 200 per 100,000 in the TB incidents in the country of origin. That is for certainly some a research gap, which still needs to be attended. Next, we need to develop methods to enhance acceptation of the TB screening and TB preventive treatment in the target populations. They were tested in the project, but they need to be more developed with other involving other communities, and to make sure that the first step in the cascade will also be covered well. Then it's important to bring down costs for screening tests, particularly IGRA. There we saw that they. Oh, I thought I had plenty of time, but I'm finishing up. Well, if you see, there are many to do still, and they will probably sorry. I'm going too fast. Sorry, I've missed. But there are many things to do still for the Netherlands, and I think that in the coming discussion we can have some further discussion on whether or not we need to stick to cost effectiveness as a criteria for implementation, or decide for TB elimination. Do we, oh, there they are, yeah, thanks very much. Another dilemma is, do we go for TB elimination, or will we go for migrant health? Should we wait for better predictive diagnostic tools and treatment regimens? And a question which is particularly important for the Netherlands is it ethical to expect out-of-pocket payment for those targeted for a preventive intervention. The last question which remains is also how to improve health education and counseling without further pressure on available public health resources. And I'm leaving you with these dilemmas and this question and giving the floor back to the chairs. I'm looking forward to the discussion. Thank you very much.
Thank you very much, Connie, for this overview. And indeed, we are now moving into the panel discussion. We will be joined by 3 more panelists from elsewhere. Those will be Dr. Marieke van der Werf, who is at the European Center for Disease Control in Stockholm. It's Professor Giovanni Battista Migliori, who is with the WHO Collaborating Center for Tuberculosis and Lung Disease in Tradate, Italy. And it's Dr. André Dade, who is with the WHO Regional Office for Europe in Copenhagen. And I think, Susan, that we will first have a few questions for them.
Yes, thank you very much for joining us for this discussion. And since you are here with a very broad European scope, let's start with a question on what, from the European perspective, would be your view on what should be done regarding TB, but maybe also other transnational health issues, and how can ECDC and WHO help the countries to improve migrant health, and maybe with a special focus on TB. So who would like to respond to that?
I can start my response, but it's a lot of questions in one. What we can say is that what the COVID-19 pandemic and the response in the European Union, European Economic Area has learned us is that there's a lot that we have learned from this pandemic, and also health is much higher on the importance, is of much higher importance now. So one example, when we, for instance, think of testing, is what to look at is what the Czech Republic did. This was really enormous. They tested all population for COVID-19 in a couple of 3 days. So we would not have thought that something like that would have been possible before the COVID-19 pandemic hit us. Whether this is a good idea for TB infection, I think at the moment not. For that, we definitely would need to have a much better test than we currently have. But it means that we should think out of the box, because all things that we thought was not possible before are now apparently possible. At ECDC, we're mainly coordinating, and we try to harmonize approaches in member states, and for that we develop guidance. The challenge is that the mandate for health is at the member states. So in that sense, we can only suggest what member states should do, and then it's up to the member states to put it into practice. It's really good to have had 4 presentations here now, where it was what was recommended is put into practice. But it also shows that we still need to learn a lot from what was put into practice, and that there are many questions that remain. I don't know whether I've answered all your questions, but else I can take it again after my colleagues have tried to answer your question. Thanks.
Thank you very much, Marieke. Is there anyone who would like to add to this?
Yes, indeed. If I may, Andrei Dadu here from the regional office of the WHO for Europe. And in our sense, we talk Europe when we consider much larger than the European Union context. That includes also the Central Asia, South Caucasus, South Balkans, as well as the integrated part of the region is the European Union. And together with ECDC, we are coordinating the surveillance network, which is reflected annually, the work that is reflected annually in the European TB report. And there, I'm very proud and humbled on behalf of both WHO and ECDC to underline that there is a specific section which defines the issue of tuberculosis among the migrants. We need to consider that structurally the migrants are could be divided into the at least two elements. Those are the labor migrants as well as the refugee and asylum seekers. And I also would like to mention that the European region is the only region in the world among many other WHO regions which has a consensus statement that has been taken back in 2012 in the framework of the Volhese workshops, which is basically the implementation of the minimum package of cross-border TB prevention and control. This statement is basically an instrument for all of the member states and the national counterparts to ensure the continuity of care for the migrants. And we, with ECDC at this point in time, are acting to facilitate at least three scenarios. One is, of course, the repatriation of the patients in order to ensure the continuity of TB treatment. The second one is the contact tracing across the border. And the third scenario is the exchange across the border with the diagnostic data. Since the migrants are one of the vulnerable population, and several times has been mentioned here, in the framework of the WHO models, it's also mentioned as a population that requires equity and equality in provision TB care. Therefore, we remain with ECDC at the service of the national counterparts and the member states to continue the support of the countries in the framework of the cross-border TB control and prevention consensus paper, as well as the continuity of care among the migrants. Thank you.
Thank you, Andrei. A question, GB, already mentioned amongst others by Dominic Senner, and I think also to some extent by Andrei, the whole issue about clinical standards. You've been very active in developing these clinical standards for screening. Can you tell us what we can expect from them?
You mean the clinical standards for screening of migrants or clinical standards for screening in general? So
I understand it's the one.
TB infection.
I understand it's the one for TB infection. Sorry about the confusion.
Okay, right. So what can I say is that we launched an initiative with the Greek Journal of a series of clinical standards on major areas, and we published in October the clinical standards for the management of post-TB lung disease, and the second document is almost ready, circulating for approval just today, and will probably be published in March, which is on TB infection. And there are other standards and development on post-COVID, on pulmonary TB, on drug dosing, etc., etc. Basically, the idea was simply to offer with the clinical standards for TB infection management a document which is complementary to the existing guidelines, which are more and more focused on, and made via the great methodology, so answering PICO questions. So like focused on main questions. And the idea here was to offer a very simple guide, simple to read, simple also to understand by clinicians, touching a little bit more the clinical aspects. So what to do practically, how to monitor the patient, which examination to perform, etc. So a little contribution to see the same thing under different angle. And this, in a way, can be a little piece that can complement what is available already, excellent documents that have been proposed by the different speakers, by Mario, etc. I have just a small comment that eventually might complement what Connie was saying before, and refers to the story of TB elimination, right, and cost effectiveness. And I have the feeling that this dream of TB elimination, that is something which we can approach, we are not that far, but that we need the last effort, right? The last mile, you know. And I think countries who can do that should enter the logic to a certain moment to make something which is not necessarily the most cost-effective intervention. Otherwise, we will never move from that line. And the problem is that in these countries, I think TB is losing in the majority of them, I would say, including my country, but not only, is losing that much the visibility or the priority that it has. So basically, more and more, no one cares. And you realize this when you try to organize something around the TB Day, which is in one of these countries. So
thank you, GB. I think you raise a very important point, and I think the point is was also raised. I think in the end, one of the dilemmas that Connie pictured, that is indeed this question about cost effectiveness. So should classical cost effectiveness considerations that we all work with, willingness to pay thresholds and so on, should that actually be a decisive factor here? And I think you just mentioned that in a phase of elimination, that is perhaps not the best approach. Maybe could you dwell a little bit more on that, and then maybe hear from the others in the panel as well?
My point is that countries who have the possibility to do it should consider, let's say, do it with common sense and not looking only exactly to the numbers. And I have the feeling that anyway, quite often in low incidence countries, things are not done, not because of cost effectiveness, but simply because priorities are elsewhere. This was my
Thank
point.
you,
So
thank you, GB. Yeah, who else of the panel could I give the floor on this? Yeah, Dominic, I would expect that you would raise your hand here. Go ahead.
Thank you very much, Frank, and thanks for your really good explanations, GB. I think the problem about cost effectiveness is not that it's there, it's that we make it more precise than it really is. So what do I mean by that? So we say it's cost per QALYs, but actually we don't know what it means by QALYs, whose QALYs, you know, and how do we calculate that? And in any case, for TB, they aren't really well calculated. And then costs, can we reduce them? At what level would we expect things to become cost effectiveness, to become more cost effective? And then of course, Connie talked about the test. And so we have a dilemma because the predictive value of the test at the moment isn't great, but that is actually a product of, let me say it bluntly, not pushing out tests, you know, as rapid as we can perhaps do in as we've demonstrated quite nicely in COVID. So you know, what we need for that is actually, we don't need just the development. The development, there's actually quite a few, I would say, candidate biomarkers which really could do it well, but it's also the commercialization. Oh, big word, you know, getting it into commerce, and actually then the costing and actually having it out on the market. That is the real challenge for that. So these kind of things will change the ball game when it comes to cost effectiveness, in my view.
Thank you, Dominic.
Thank you. We have a question from the audience, from Dr. Vilis from Turkey. He is asking about algorithms that are used for asylum seekers or other refugees who do not have passports or national ID cards. I think we can get a few answers from different countries. Ineke, would you like to start off for the Netherlands?
Yeah, so I think there's all, so in the Netherlands, all asylum seekers who enter the Netherlands, they are screened mandatory at entry. And then what we did is replace the follow-up screening with LTBI or TBI screening. So those persons, they don't have a Dutch service number, as we call it, but they have some kind of identification number. So I think the problem here is that anyone who comes in without a identification number will not be registered as an asylum seeker, because they are yeah, as we call it, illegal. I'm not sure if that is a sensitive name to it, but we see them as illegal, and then they will never enter the system. So that will be a whole different group, I think, to see if we can. I'm not sure. Maybe Connie, do you know the TB incidents among people who are illegal in the Netherlands, who don't have a service number? It's very difficult, I think. But yeah.
Well, actually, we did. We tried to figure out the incidents among, but this is a very heterogenic group.
Yeah.
So the undocumented persons, they come from all around the world. They come from low burden regions as well as high burden, and that means that the actual incidence of TB among undocumented persons in the Netherlands is not really extremely high. But that said, we know that they are still a risk group.
Yeah.
So, but since they don't report to our immigration services, either as an asylum seeker or an immigrant, they are invisible for us, and we can't screen them.
Yeah. So I think Mario would like to reply as well.
Yes, thank you. No, I was meditating on that, and just to say that the study I presented in Milan was among asylum seekers, not among migrants. So by definition, those are asylum seekers. Those are those who land in Lampedusa, right? And are distributed then in the various centers where they are received. But to answer the question, I would not make any distinction. To me, the right to health is for everyone. That is what the Italian Constitution in Article 32 basically says. You know, the health is a human right, and in the interest of the individuals and the collectivity, or whatever, the community, I'm just reading it, the actual article there in front of me, is guaranteed by Italy to everyone. So I would never make a distinction between asylum seeker and migrants. I would just provide care to everyone. I would not go into cost effectiveness type of analysis, for the reason that have been very well presented by GB, by Dominique Zenner. So it all depends. You know, we have done a lot of cost effectiveness analysis at WHO. We were using it, obviously, when this was favorable. But again, knowing the way it is done, and knowing the modeling type of approach, knowing how you do economic modeling, then, you know, there is a certain degree, if you like, of flexibility around the numbers that in the end you find. But again, in a country that is going towards elimination, in a country that has to provide access to health and prevention to everyone, cost effectiveness, in my view, becomes a second type of consideration. So, no, in other words, I would just go for access to everyone, regardless of their status, when they are in a certain territory.
Thank you, Mario. I think that's a great point. And I think it's also a reason to circle back to the realities on the ground. David, there is quite a bit of bureaucracy involved in the end, isn't there? And what's your take on it? What do you think is what are the implications for the people whom we are concerned with, the migrants with regard to, and especially asylum seekers with regard to these kind of screening programs, from your experience?
Well, I think when it comes to approaching we have to speak from a very specific context of asylum seekers or newly arrived refugees, because they find themselves in a highly bureaucratic system of asylum and camping, etc. When you come up with health intervention, there's always a difficulty to make a distinction between what is consent and what is for your benefit and what is required for you to do. And in that is often what you see the challenge for migrants to make also an informed decision whether to participate or not. But outside that, I think participation becomes then a different concept. People would have a broader understanding of, especially when they stay 5, 10, 15 years in the country, then their understanding of what is a health perspective, what is a bureaucratic perspective becomes different.
And can we do better here? Because we usually look at outcomes and we say, oh, well, we've done tremendously well because so many people have accepted. But is that always the reality? I mean, is it indeed the choice of people?
Yeah, I mean, it's in our case, in our project, I mean, it was quite an interesting project. And when we provide the information, when the education that we designed eventually, it came across as a necessity, and they would see it in a context of what other hospitality offers that was provided for them. But consent is always a very nuanced concept. So in the setting that you find them in asylum seeker centers, in reception centers, concept becomes a little bit difficult to see. But in our experience, it was often accepted as something, as part of the hospitality that was offered during that time.
Thank you. I see we are sort of very close to the hour. I think the one thing that we didn't decide is who would close.
Knut is waving his hand.
Knut is waving his hand. It's about time, but I think maybe we will have another minute for Knut to give a comment here before we round up.
Yeah, it's been up for a while. I wanted to comment on the cost effectiveness. I'll prioritize that one. And I need to strongly disagree that we should question the cost effectiveness approach. What it has done, and we've come very far actually, and by bringing health-related quality of life into the equation, we have started to harmonize with the rest of the world and all other health conditions. That is what really matters. It's challenging to measure, but it's helped us to move away from incidence and transmission rates. In other words, we're focusing in this area on migrant health. Now, Connie, you raised the question, should we talk about migrant health or should we talk about TB elimination? What we have shown, now more and more countries have done this, is that this is the cost of reducing TB incidence by doing latent TB screening and treatment. Now, we can show how we can bring incidence down by doing that. But it doesn't mean that we invest now and we have done TB elimination, and therefore we have no future cost, because we need to continue to do this in the low incidence countries with a high proportion of cases from migrants until TB incidences decline globally. So I would say TB elimination, it's a global issue. And then on the national domestic level, we need to focus on migrant health. Now, cost effectiveness analysis may be complicated, and we often fall into the pitfall of saying, trying to dichotomize this, they ask the question, is it cost effective or not? What we have done, and we have several countries now showing how it varies across countries, and we start to understand why. And then we find the ways to reduce the cost or increase the effectiveness, and that's really helpful. But if we say we don't like the results because we don't have that willingness to pay if you look at those outcomes, I think we're fooling ourselves. This is the argument that will matter in the end of the day. And then we need to ask different kinds of questions with regards to TB elimination. That is the massive investments on the global level to bring TB incidence down. Otherwise, we won't solve it. Sorry. That's my small point I wanted to end it with.
Very realistic view, I would say. Thank you. So we are over time, so we will now end this symposium. I think this was it was very nice, interesting, and I really would like to thank all the speakers and the panelists. The symposium is in honor of the completion of the thesis of Ineke, who will defend this officially tomorrow. So you're all welcome to also attend that defense. Yeah, thanks again, and we'll see you hopefully tomorrow, and otherwise certainly another time.